So let's go on to the next presenter, and that is no other than Dr. Divyansh Mishra, and he won the Colonel Rangachari in 2018. He is a consultant in vitreoretina and ocular oncology in Shankar Eye Hospital, Bangalore. And just before the session started, he was speaking volumes of his mentor. And I'm sure right now also, he will tell us how he did his project and how much his mentor has helped him in the project. Welcome, sir. Maipal, sir.
Thank you. Sorry for late joining. I have to work also.
Sir, you are working very hard.
Yeah, I have to catch up.
I also just came actually in time. Danda sabke upar hai.
So, Divyansh?
Yes, sir. Sure. So, good evening all, and I'm really honored and thankful to be a part of this August gathering where a lot of my mentors, a lot of people whom I have learned many things, I am presenting in front of them. So, and it being an auspicious day, I want to bow to all my mentors, my teachers for making me what I am today. So the topic of presentation, which was given to me, is my journey. I would want to convert it to R. No financial interest disclosures in this. Most importantly, a sincere thanks and again a bow to my mentor, my boss, Dr. Mahesh, and all the team which was there at that time. This was in 2018, my fellows, my colleagues, my senior colleagues. So when all this started, so it was just before I was finishing my post-graduation and I was trying to apply for a VR fellowship. At that time, when I was searching in AIOS, I could see that my mentor, Dr. Mahesh, had an award, a RANGACHARI award in 2009. And the award was a very frugal innovation, which had more clinical association and innovation associated with it. So this comes to my or our work, which we had worked at that time. So we thought of a problem statement. What was the problem statement at that time? The statement was that, can we get a wider OCT scan with the presently available OCT machine? A little difficult part. So the problem was that when we evaluate with an indirect ophthalmoscope, we can see a lot of areas which has problems. But when we do an OCT, we get a very constricted image that includes just the posterior pole or probably 12 by 12 mm, which was a maximum scan available at that point. As in this case, we are not able to see what is happening on the nasal side. We can see that the membrane is over the macula, so we would not intervene from there. But I wanted to understand what is happening on the more nasal side, or where is a more safer side to intervene in such cases. Again, this scan is also not giving a complete understanding. So this was another case which was more intriguing, that had some kind of a membrane, vitreous membrane just inferior to the arcade. And when we do a scan, I know it has just vanished out of the scan because the scan is so small. Can we increase the length of the scan to understand what is happening beyond that? Then comes the point of brainstorming. So what is brainstorming? Brainstorming is to evaluate your problem statement, do a literature search, review the techniques which are possibly available, and look for the feasibility of those techniques. And then the most important point, trial and testing, which would be recurrent and repeated. And yes, then you review the images, whether the quality of images are good enough and projectable. Then came three approaches, which we boiled down to. First was the montage technique, which was possible in our machine. Second was a montage technique with a much advanced and the better machine at that point. But yes, there was a frugal innovation somewhere which was published, something which is called as an extended wide field, which was utilizing a 20 diopter lens. So what are the pros and cons? So we decided, yes, the pros were that we have the machine, we can do it. But as you can see, a lot of artifacts. So a lot of scans need to be done. And yes, it needs to have a separate montage, which has to be prepared on a separate software. Fixation was a big issue. So this was out of the question. And yes, big machine, which has good quality, better inbuilt software for a good montage. Again, our institute cannot afford, considering it is an NGO. So unavailability of machine, this is also out of the question. The third one, the frugal innovation, which was more readily available, like a 20 diopter lens, which can be put onto trial lens and can be done, but it requires a learning curve and it gives a minimal increase in the size of the length of the scan. So this is how we utilized it, that putting onto a trial lens, a 20 diopter lens is put, and very easily you just take it as you do a normal OCT, putting on the trial frame onto a patient, and then either by a automatic acquisition mode or by a manual mode, you can take good images. And this is what we could achieve just with a 20 diopter lens. As you can see the image on the top, we can see with the normal conventional OCT, and below one is with the 20 diopter lens. We can see that there is some kind of a secondary membrane and a proliferation which is going into the vitreous cavity. So we know we have to peel over here, which is more nasal, a safer side. We thought it is detached beyond the disc, but no, there is again an attachment temporal to it. So a wider scan was giving us a better understanding, as we can see, because it was giving a wider view. And yes, in the patient which had more intriguing signs, as you can see, it's not only that there is a vitreous membrane, but there was something more sinister, that there was a temporal schisis just because of that. We thought, can we move the goalpost a little further? Can we do something extra? Can we do more wider and much wider OCT? Again, the point of brainstorming started, where we reviewed the literature and then feasibility of the technique, trial and testing. So we came down to one point, something which is called as a nodal point, which is where because of the lens, it is there is a point where it gets focused just into the lens. And if we utilize high power plus lenses like either 20 diopter or 90 diopter, it's shifted more anteriorly, and that's how you get a wider field of view. We thought, okay, this may work for us. So we tried multiple lenses which we have easily available in our hand, like 78, 90, or a wide field, digital wide field, or a Mainster. This is a brainstorming which you are hearing, which is occurring live, where we are doing a trial, that what is happening and what is happening once we keep the lens. What are the pros? What are the cons? What would the patient see? What all problems which we would see? So this is right now, it looks like we are just blabbering words, but this is what made us understand how to go forward. And then we could achieve this, that once we switch to a manual mode, make it to a myopic or a high minus side, take the lens, how we keep it like a slit lamp biomicroscopy, and then center it over the pupil, and then manually change the Z axis. As you can see, a wide angle view is very, very beautifully seen. And if required, some kind of a minimal maneuvering can be done. And we utilize multiple DIY lens holders. Like this is like a coffee cup, which we have cut into half, and then we have attached the 90 diopter lens. We have utilized the full aperture trial lens also. Multiple ways of trial assembly, which could be put on to the OCT machine, and either the patient can wear it, and all those trial and testing were done. Multiple lenses which can be put on, like 220 diopter, 110 or 20. And this is what we can see. A 10 diopter can give you this wide angle. A 20 diopter would give you this wide angle. A 30 would give you much wider, but yes, a 90 would give you a really, really wide angle view of the OCT. And in clinical scenario, it gives you a better understanding of VR interface, and the quality of the scan is also very repeatable. Whether scientifically can we prove it, is it wide enough? So we utilize the ImageJ software, where we calculated the area of which the OCT was showing up. As we can see, the expansion ratio showed up as 1.77. So what does that actually mean? That it implies too that we can actually have a widest angle of OCT, as you can see over here, which is approximately near to around 20 mm, which is much, much wider as 20, and really 1.7 times of the normal scan. Can it be done in other machines? Yes, it is very well can be done in other machines also. As you can see in older machines also. Octa, yes. As you can see, this is the widest field of Octa which we have seen and we have published also. That it's not 12 mm, it's a 20 mm of a widest field which you can see. Yes, all the studies come with limitations. There would be less than 10% of poor quality images. Fundus photos cannot be taken. There can be some lens edge effect or rim artifacts can be then. So what does the innovation show us? That we can double or triple the field. Any OCT machine can be utilized. The wide field Octa can be done for a 20 by 20 mm, and it can be done in a non-mydriatic way. Most importantly, it's a non-invasive and a non-contact method. So learning from our journey, first and foremost, necessity is the mother of invention. We don't have advanced gadgets, but frugal innovation is about delivering more value at lower cost to more people, so that each and every one of us can have a widest field of OCT and persist for progress. Thank you, and sincere thanks to again my mentor for all his help. Thank you again.
Thank you very much, Divyansh. And now over to Dr. Harbans Lal sir and Peru and Bhalla for the discussion.
Yeah, I think it was a wonderful innovation. And like Dr. Divyansh said, we may not be having the advanced machines, but we have one thing we have to be proud of is that we Indians have advanced thinking, advanced intellectual capacity. And that's what Divyansh did. Just a frugal way of how we can increase the width of OCT scan. He's done in a brilliant, innovative manner. And I think it's a wonderful thing. So you don't need to have the best gadgetry, the most expensive gadgetry. But if you are innovative and like you did, the way you try to hold, it is not easy for us to hold 78D or 90D, and where we are seeing the patient's eye. Here you were doing through OCT where you are not able to see, but still I think just with the perception you were able to center it on to the pupil and delivering so nice and I think wonderful images. And then making innovation with coffee cups and holders. Brilliant innovation. I really salute you, Divyansh. You've done a wonderful job.
I would only thank my mentor because all his inputs were there in whatever we did, and all his support was there. So my mentor, Dr. Mahesh, thanks again.
Harbans sir.
Is Harbans listening or?
Harbans Lal sir.
Comment, sir, Dr. Lal sir.
Harbans?
Dr. Harbans sir?
Yeah.
Yeah.
I think it's really fantastic innovation and very good idea. I don't know how practical it is for the others to emulate. So whether it is really easy to use or whether it is really too complicated for an average eye surgeon to use it. That I would like to know from Divyansh.
This is one of my videos where I am doing, but all of our fellows are very capable of doing such kind of OCTs. So as you can see that we are on to the next thing to try to make a kind of an adapter which sticks on, as I showed that there was a cup and then which can be stuck onto it. And then, so we are working on that, and we are working to make a kind of an adapter which can hold on to the lens and then avoid all this maneuver which certain people who are trained into it can be done. So yes, obviously we are working on it.
Great, Divyansh. I think we look forward to that adapter because it looks that he has made a wonderful innovation and a very good OCT pictures. But at the same time, maybe because most of this is done by optometrists and young people, I really don't know whether it will be easily adaptable to others' practice or not. So there's some, I think the development of some type of attachment would be great.
Sure, sir.
Thank you.
I think, sir, one thing that is so important when one listens to Divyansh, the question that was answered or the question that he asked himself, the amount of the extent of what the OCT was giving and is still giving to all of us is so small. If we could expand that OCT and if we could see a panorama of the retina and how much that would have helped the VR surgeons, not only for the surgery, but also understanding the extent of the disease. And I think such a simple question, but it was he who struck it. So I think the importance is to see the extraordinary in the ordinary findings. Hats off, Divyansh.
Thank you, sir.
I think one more thing that has really come out is that the mentors play a very important role. So each of the presenters who have presented here, some on behalf of their mentors, and it is, hats off to them for doing this and for mentoring such bright minds and then allowing them to present. People may mentor but may not, I think that's the greatest thing.
Very true, man.
Right. Absolutely. Well said, Namrata. Absolutely correct.